Alrighty, everybody, welcome to the channel. Today I'm going to go over the way I approach EKGs and what this means. So, first thing I do, I'm getting an EKG, obviously in real life, this is because I'm assessing a patient, right? So, I'm looking for ischemia, I'm looking for rhythm abnormalities. Is their heart beating too fast? Is it beating too slow? Is it beating in the right order so that blood can flow through the chambers of the heart the way we know it? And so that's important. And so understanding that, this is my approach to the EKG from a functional perspective, and I kind of use the anatomy of the heart to guide me, because that's what I care about is what is the electrophysiology behind this heart's rhythm, and is it causing the heart to work effectively, or is it causing the thing that I'm looking for in a patient? So the first thing I do is I always say, and you'll see in my videos, I say, look at the forest. So what that means is the forest is the EKG, and the trees are the leads, or excuse me, are the QRSs. And so what I'm doing is I'm looking for the regularity. Are they beating at the same rate every single time? I know that the sinus node has, it's pretty regular and it beats from 60 to 100 beats per minute. I know that if there's an AV block, say a second degree AV block, I'll have a beat, 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 drop, beat, 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 drop, right? So I can look at that in the trees of a rhythm. I can look at the QRS complexes real quick. Are they nice narrow QRSs? Or is there something that's causing the QRS to be wide? That tells me, an idea of where's the conduction system, what is it using? And so I can start to narrow my differential diagnosis of this EKG strip and, wide versus narrow, regular versus irregular. Is there a pattern to the irregularity or not? And then from there, once I get my idea down of what's going on, I'll continue. So I'll bring you guys to our EKG here. And so let's kind of talk through what I look at in this case when I'm looking at the forest. So this is my forest. I'm looking at my trees. I'm looking down, say at the bottom here, and I see a tree. They're all happening kind of on time, right? I look at them, they're narrow, real narrow. They look like they've kind of got this PQRST complex to them. Nothing's popping out of the screen when I look at this. Okay, so that's kind of the way I might look at the trees. I see just P waves are marching along. I don't see any weird stuff in between. Just getting a quick little look on maybe what I'm going to be dealing with. Next thing I do is I say, okay, what is the atria doing? That's important. And so by what I mean by that is, I'm looking at my P waves, and you're looking at the P waves at how fast are the P waves going? Are the P waves, the rhythm, right? Are they maybe the same every time, or are they changing? Are the P waves associated with the QRS complex, or are P waves just kind of all over the place? So when I'm looking at the atria, I'm also looking at the ventricles in a sense, right? Because I want to see, is the atria coordinated with the ventricles? And so as I look here, right, part of that, P waves are generated by our sinus node. And we know that the sinus node beats at a predictable rate. And so I would come here and I also would, maybe look at the rate. And so I would kind of mark a solid line and 300, 150, 100, 75. That's maybe 75 beats per minute. Okay, that's a good sign, right? And so when I look at my P waves, I'm saying, is the P wave driving this 75 beats per minute? And I look here, I see a nice P wave, P wave. I don't see any P waves in between. P waves are typically sharp. T waves are typically broader. And so it's a good way to discern to make sure there's no P waves superimposed on these nice T waves. And I know that my P wave axis, because I know that the heart, the right atria is high up, and this is my atria here. And then here's my ventricles. And I know that when the atria fires and depolarizes, it's going to depolarize from the upper right-hand corner down to the lower left-hand corner, which means our P wave should be going down and left, which means down would be positive P waves in AVF. There's our positive P wave in AVF. And leftward would be positive P's in lead one. So that's how I can be like, check the sinus rhythm. The next thing on my list here is it says measure intervals. Really, if you think of measure intervals, we've got 3 intervals. We just looked at our atria, so what's the next thing in line? Our PR interval. Our PR interval is the time it takes the AV node to capture signal from the atria and send it to the ventricles. So I first measure my PR interval, and it tells me what's next. AV node, is it conducting? Is it conducting every time? So I look throughout the EKG, because if I measure it at one point, well, that might be a normal beat, but is it normal again the next time? The next thing you'll measure, again, if you haven't already, is your QRS. That's going to let you know, how is the conduction in the ventricles? Remember, the QRS duration is time. So that'll tell you, is it using the His-Purkinje system or not? And then the last thing is our QT interval. We know that our QT interval is our repolarization time. This is important because repolarization needs to occur in a timely fashion to be ready for the next beat. And if it's not, then we can become maybe pro-arrhythmic to other EKG rhythms. And so when I do that functionally, we just looked at our atrial activity. And so let's do our intervals. The first thing will be our PR interval. So pick anywhere, maybe here we've got beginning of our P, beginning of our QRS. And what I'm looking for is I want to make sure that it's less than 200 milliseconds or 5 boxes, so off boxes. And I want to make sure that it's greater than 120 milliseconds because the AV node typically doesn't work faster than that. And if that's the case, we might have some pre-excitation. So we look for that lower end of normal because we know that if it's lower than that, we might have like Wolf Parkinson White. That's not the case here. So I see that this PR interval is good, but I'll just scan throughout and I say, okay, good. Okay, good. Maybe over here, good. And the fact that I'm seeing QRSs occurring throughout even adds more evidence that there's no AV node dysfunction or AV block in the sense that there are no drop beats. So remember, if you understand cardiac physiology, then this is going to make your, developing a differential diagnosis as you're going through these steps much easier. So remember, I looked at the forest at first. I kind of just took a glance at the trees of the forest, and then I went to kind of top to bottom. SA node causing atrial depolarization. Let's evaluate that. Next thing we evaluate is our AV node as it captures that signal. Okay, let's evaluate that. We look at our QRS duration as the AV node passes it down into our ventricles. And we know that this is nice and narrow, and that tells me that it's taking that highway system that we call the His-Purkinje system and allowing for rapid ventricular depolarization. If it was wide, our differential kind of changes. If it's a wide complex QRS, we might think, well, okay, are there P waves? Are those P waves causing ventricular depolarization? If so, that means that that's coming from the AV node. If it's coming from the AV node, what are some things that can happen below the AV node that might be a problem? Bundle branch blocks, Hemi blocks, Wolf Parkinson White. If there's not an atrial function that is driving the ventricular depolarization, we might think that these might be coming from the ventricles, like a ventricular escape beat, right? So you're just mounting evidence throughout this entire process. And then the next thing I'll do is I'll actually evaluate, now that we're in the ventricles in our pathway, I'll evaluate the QRS axis. We know that the QRS needs to be going down and left as well. And that means that we look here, we have a QRS that is up in 1, is up in AVF. I know that's going down and left. It's a normal axis. And so it's important to evaluate our axis because that can tell us if the left ventricle or the right ventricle is carrying its electrophysiologic weight. So what I mean by that is if the left ventricle is hypertrophied or if the right ventricle is hypertrophied or if there are bundle branch blocks, it's going to change this axis. And then our differential diagnosis of the cardiac conduction is going to change. So that's how I evaluate the QRS axis. The next thing I kind of do in tandem, I look for pathological Q waves. Pathological Q waves, remember Q waves on an EKG are when the initial deflection of the QRS is negative. So when I've got my P and then when I have a deep Q wave, that's a pathological Q wave. And that's really what that's saying is there could be a previous myocardial infarction in that anatomical region that is in that lead. So I look for Q waves, and at the same time, and it's got to be pathologic. I mean, it's got to be deep. And at the same time, I'll scan the same areas for ST and T wave abnormalities. I look for elevation, I look for depression, I look for T wave inversions, and I look for T wave morphology changes. And that's important because that could clue us into some metabolic disturbances, can clue us into ischemic changes or just chronic disease. And so I scan my leads anatomically. So I'm going to start with the lateral leads. I'll start with lead 1, lead AVL, V5, and V6. Those are our lateral leads. Then I'll go to the inferior leads, which are leads 2, 3, and AVF. And then from there, I'll maybe look at the septal leads of V1 and V2. And then I'll go to my anterior leads, which are V3 and V4. And everyone says, yeah, don't worry about AVR, but AVR can change in a predictable fashion, depending on if it's infarction, if it's pericarditis. So I always take a look at AVR as well. So I scan through anatomically. And that's my EKG approach. At the end of that, you put it all together and you have your diagnosis. And so, kind of as I recap this, we look at the forest and we say, what is the overall gist of this rhythm? What are some things I can start to narrow down my thought process? Is the QRS narrow? Is it taking the highway system, the His-Purkinje system? Are they occurring regularly or are there dropped beats? If so, what does that change my mind? I look at my atrial activity. I look at the morphology of the P waves to see, are they coming from the sinus node or are they coming from somewhere else? Do they even exist? How's my sinus node even functioning at the get-go? Or is there atrial fibrillation or flutter? On top of that, you can figure out, are the P waves driving the rhythm? Are they associated with QRSs? And as you venture into that associated with QRS kind of question, you start to think about the next step. Measure our intervals. PR interval. How's the AV node doing? Is it conducting every time? Is it within 120 to 200 milliseconds? Then we know the next thing in line is our QRS as it passes the signal down to the ventricles. Is that narrow? If not, is it because of a bundle branch block or is it because of ventricular ectopy? And then lastly, we never forget about our QT interval, because our QT interval is important to make sure that we are repolarizing on time and keeping our myocardium safe from arrhythmias. And QT changes obviously can occur, to so many different reasons. I take a quick look at my EKG or my QRS axis to make sure that the vector of depolarization within the ventricles is appropriate and that there's not potential hypertrophy or blocks that would skew that. I look for evidence of old infarctions as pathological Q waves, especially because that puts people at risk for heart failure and other cardiac disease. At the same time, I'll look at those anatomical leads. At the same time, I'll check those ST and T wave out, make sure I'm not missing anything scary, and you put it all together. Does that fit the clinical scenario or not? So I hope this helps, and keep crushing EKGs.